Thank you. Thank you, Dr. Rajan. A very good afternoon to all the delegates. And at the outset, I would like to thank the Indian Nuclear Society and the Atomic Energy Regulatory Board for inviting me to give this talk. And it also happens to be the election day, so they brought me to do my national duty from Mysore. So I did my voting franchise right in the morning. I'm also happy to see at least two batchmates of mine, Guptaji and Bamraji, are here. Other than, of course, a large number of my mentors, including Dr. V.K. Gupta and so many others. We are friends, we are going to shift gear. We've been talking about till now, perhaps, even though yesterday I was not there for 1.5 days, things about an extremely well-organized, if I can use the word monochromatic, unifocal application area of nuclear power, nuclear energy related. We are now moving to a very diverse area where it is very, very heterogeneous. It is no more a harmonious community, very heterogeneous community, as Rajan was just started telling, of this medical and industrial thing. And of all the applications, medical has been the most popular because of the necessity, need-based. I am pretty sure practically everyone sitting here, either for one of you or one of your close family members, have had a radiation-based medical procedure or an investigation. So it's such a common thing. So with that, when the topic came, but I knew I am also going to be talking in a general conference, and it's not only addressed to the RASD staff like of AERB. So there will have to be quite a bit of a generality. But anyway, I'm very happy this topic had been included thoughtfully by the organizers instead of all being only on the nuclear power and the nuclear fuel cycle related. So to give what's going to be a broad content, obviously some introductory text about what is radiation medicine, what's the kind of the global volumes involved, and what are the international agencies, entities which are all actually involved in that, etc. And then we do have very, very specific challenges. And the very important point is the preceding talk by Koleji. I hope he's not around. And so, he's given such a good introduction already to this topic. And his own talk, if you remove the word plant and put the word radiation facility, the radiation protection with reference to the radiation facility, industrial, medical applications becomes so pertinent. So with that, it's good. So that way it is nice. But at the same time, these are all purely personal, professional views analysis. Coverage will be to the extent possible global and national together. But as a retiree and only an advisory member to AERB committee, I would like to make that bottom line clear. Views are not, however, attributable to AERB or my former association with the International Atomic Energy Agency. Now, coming to the medical applications, everybody knows, starting from simple X-ray picture to interventional radiology, you undergo a coronary angiography or so, or to cancer patient in the family, a radiation treatment. They have been extremely common world across. Even if you are not a member, a country is not a member of IAEA, they would also still be having a radiation medicine certainly in that And these diagnostic therapeutic procedures are necessity-based. Already the justification, which is the fundamental principle of radiation protection, is already built into that. And in IAEA, other than IAEA, the World Health Organization, even though they are much more concerned about the overall health-related aspects, they are also equally much there. It cannot be that only IAEA will dictate because, the radiation is involved. The WHO is very much there, and together whatever they do becomes an extremely important document, as we will be seeing in some more of the later cases. Then professional bodies, already mentioned, came of ICRP, IARP or IRAP, and in our own Indian national context also, IARP, other bodies Then the national regulatory bodies related to the radiation, nuclear and radiation safety. That's like our AERB or ASN. They are also extremely imperative with reference to this. Now, what's the kind of volumes that we are talking about? There are there are many, many applications of radiation, but the major ones, if you take, they will come under the three. For ease and convenience, collectively I have put the name radiation medicine, or, we are a lot of, acronyms. Even in the morning, many acronyms were used, and some of the audience were even asking questions, what about it So, out of the three, the most commonest known to everybody is for the cancer management, what is done using the radiation oncology or radiation therapy, RT. The cancer care, that's something extremely well accepted. What's about the volume? I am giving ballpark figures. These are almost correct, but I don't want it to be quoted as exactly accurate up to the second decimal or so. 8+ million people, treatment procedures are what takes place per year in this system of radiation oncology, only in the area for cancer. Then comes this other topic, nuclear medicine. We will be covering what it is like. There it's nearly 5-fold more, 5 to 6-fold more currently, I would say. This involves diagnostic and therapeutic, roughly in the range of 80 to 85% diagnostic, 10 to 15%. But what's more important is this is not confined only to the cancer care. This goes across to many, many other areas, cardiology, infection, you name it, you have it, including a pediatric nuclear medicine wing. Then comes this very, very extraordinary volume of what's known as diagnostic radiology. And interventional radiology is relatively less, but still that's also extremely large. That comes to be nearly 100 times more than what's the nuclear medicine volume. No wonder that's an extraordinarily big challenge globally, including for India. And that's something which, out of convenience, I'm not going to be much talking about in my talk. Because, you cannot be covering everything in a short talk. So, very convenience, and the greater amounts of importance is there in the RT and the NM from the safety point of view, so they are only going to be covered. What about the radiation professionals? We are talking here about few million people, medical, paramedical, technical staff, all put together who are delivering these services in the healthcare thing, comes to a total amount of a few million. There is some number like 5, 6, 7, but there has not been a unanimity, so I didn't put a number there, unlike the other cases where we have put the thing like. So with this background of what's the broad medical applications and the kind of the volume, we have to move to protection and safety. And that's where I really appreciated the organizers' very thoughtful arrangement of Cole's talk, and giving him also a focus not to go into his OPSD angle, but directly do that radiation protection. Because that has really become a very nice introduction, and those of you who really enjoyed that other talk would be able to follow, because much of this we need not really be repeating it here. What's happening here is harnessing the benefit of radiation-based procedures for patients' diagnostic treatment. Together we call it patient management. We use both sealed sources and open sources. And that's what it makes it. In the radiotherapy, it's by and large sealed sources. Nuclear medicine, it is completely open sources. That creates many things. And who are the directly sort of people involved? Obviously, occupational workers will have exposure. In addition, there will be trainees, other staff associated in hospitals, people, they all will be likely to have the occupational exposures. Then the patient who is deriving the benefit, they certainly have their own thing like. And for certain of the patients, there will also have to be carers and comforters. They might be requiring some help, so there would be somebody who had to willingly be volunteering, and therefore they also are likely to be receiving the exposures. Radiation exposure is inevitable. Obviously, the fundamental principles. I'm very happy, once again, I'm repeatedly quoting Koleji because he has already defined and told you everything on what is justification. And then comes the optimization. In justification, at least in the medical part, it's absolutely clear that's a must for the patient's sake. So it's done. But then when you come to a diagnostic therapeutic cases, yes. But diagnostic cases, there can always be the question whether you could have done it by some other means. But the clinical judgment the doctor has to do, they are going to do it, and probably multiple times, repeated times also, as we would say it will come. So those three fundamentals, justification, optimization, dose limits, and along with that the ALARA, they are together, you call it as management for the radiation protection and safety. This leads to every one of the institutions in the radiation medicine requiring to have custom-made radiation protection program, RPP. These are all emphasized in our documents and globally also in the other things. For example, in the AERB safety codes, most of them now, they're kind of a very harmonious method of making it is coming. In that, the chapters 3, 4, 6, they are the ones. The 3 is all about the design and the entire installation, all the features. 4 is the operational safety. 5 is on medical exposure. Obviously, in radiation medicine, it will apply. Dropped it there. And then the 6 is the handling of the emergencies and situations like. Then the word RSO, RPO, this was also mentioned, but when you talk about a radiation safety officer in a nuclear establishment, in the well-organized, homogeneous organizations versus an RSO in a kind of an industrial or medical facility, we are talking about two diametrically pole support like. It is often, they may not really have an adequately kind of a empowered working arrangement, but on a paper, our requirements are there should be a designated one, and we do recommend they should be fully empowered, which may or may not really be taking place, effective functioning. And then the licensees, it comes to be the absolute responsibility. Again, that statement was there in Cole's one of the slides, the licensee being directly responsible for fully all the part of it. So that becomes extremely important. And the human factor. whether it is an RSO, the licensee, or a radiation professional, man is there, and that really is a key aspect of the entire thing. Now we come to, that was the basics, basis of your radiation protection safety, addressing it this is where in the kind of the medical healthcare application we talk about, we are distinctly different than from the nuclear. In the nuclear area, the entire technology and the safety, everything comes under the nuclear umbrella. Whereas the moment we are talking about healthcare sector arrangement, there are two clearly different domain aspects, because there is going to be the medical management authorities of the country, the health ministry, health authorities will also be involved, because there is a kind of a technology per se angle, as well as personal radiation professional. When we say the personal, the qualification with reference to being a technologist for that particular medical application, whether it is radiotherapy, whether it is nuclear medicine, the medical aspects of the technology are also there. That's certainly not under the domain of AERB. So we have this overlapping arrangement, and what is needed is, invariably the two will be two distinct authorities will be doing, and they will have to be working in unison. That's what becomes important, because if you take a person, all the radiation protection safety knowledge has to be there to perform the duty as a radiation procedure in radiation medicine center, but they also need the basic medical part of the application technology knowledge itself also. That becomes extremely important. The same thing applies other than the man to the machine, whether it is an imaging system or a therapy delivering system, you do need the technology based per se, a kind of a regulation and arrangements other than the radiation safety related. That's why I put the two together. There are two domain aspects. Thanks to Homi Baba, we have the atomic energy going on for 60 plus years, 70 plus years perhaps. So we are better organized, we have a better arrangement. Whereas the health ministry, they are also seized with many other things, infection, other kind of a calamity, pandemics and so on and so forth. They might not have yet really kind of come to a point where all these advanced technologies are well absorbed. But yes, there have been efforts there is a National Commission for Allied and Healthcare Professions Act, which had come only in 2021. AERB people have been involved. It tells beyond the medical also, there are so many other professionally qualified level people who are required for the success of the procedures, and they were not there. That word allied professions, that's extremely important, because whether it is not only for the radiation related medical procedure, you take any other thing, you go into a critical care unit or ICU or a lungs specialist, lung performance, function testing or a liver function testing, those technologies, it is between the sisters, nurses are different, doctors are there. Then there is a technology group scientist or technologist, whatever you call, and that needs to get regulated, and that's what is supposed to be coming up through that National Commission, and that would help, because this overlap cannot be removed. There will be overlapping area, AERB radiation safety part of it we will be doing, but then the technology per se, the science per se of that medical practice, that also is important. That can only come from the other kind of regulatory thing till any legal empowerment is there. In many of the countries where they are better organized, well organized, the health ministry may be taking care along with all the adequate inputs for the radiation regulatory part. That's why I said mostly governed by two distinct entities in many of the countries, and they have to work in unison. Here already we have interactions. Our AERB is represented in quite a few of those committees, etc. Then coming to the safety part of implication itself, much of the time, this also came up in some discussions in the morning time, there is an interface of the quality of the entire technology, procedure, process that you practice. The quality management system is also a very helpful thing. When that is addressed, the safety is also inclusive of that, and it also gets addressed And with reference to the radiation medicine procedures itself, when we come, things like your quality assurance, and in many of the things, the dosimetry is the most important. And once you say dosimetry, calibration, the secondary standards laboratory, etc. comes into the picture. Apart from the radiation protection program, the periodic safety review, not in the level of the power plants but for any one of the operational facility, they become important. And I already mentioned the problem of the RSO, radiation safety officer, or globally what is called radiation protection officer. Unlike in a nuclear area like hospitals or other places, it's a requirement they may put, but when it is not duly, fully, effectively used, it fails, it doesn't help the service So from the AERB side also, we have been trying to coax and tell that RSO system should really become much stronger and be able to be functioning. Now, addressing the point, like to coming to the managing it, like naturally you need multi-pronged approach. But my one point with reference to most of the medical, or for that matter other industrial, other things, will be the commitment of the management, licensee. That's something absolutely uncompromisable. Unless that is really clearly there, the safety protection activities are not going to be able to really be effective as much as one wants. Because they owe that to two people. One is to the workers to control the occupational radiation exposures or remaining within the prescribed limits, and to the patients because they have to get a good efficacious diagnosis or a treatment without compromising the safety. So the management commitment with reference, so that means the licensee part with reference to our radiation medicine center, all the radiation medicine facilities become extremely important. And this is sort of very closely linked as to what you consider and cultivate and create as the radiation safety culture. It has to be all-encompassing and all stakeholders and every action from end to end. Like it cannot only be thinking like, I'm only looking at the radiation safety process. It has to take into account the medical procedure, the intention, its execution till its completion. It has to cover both of them. So naturally, with reference to the patients, when we want to specify many things, the health ministry, medical councils or professional other bodies of that, they also come into that in addition to our own national radiological regulatory process. But ultimately, that medical person, that treating doctor, that institution, they become really the deciding authority. With reference to a particular patient, they are going to do a certain procedure or repeat a procedure that is a clinical judgment in terms of my need to help and save this patient, I am doing it like. So while all these prescriptions will be there, eventually it is the man, the doctor there will have to be making up the decision. Workers wise, yes, they get exposed to radiation, and any of the repeat procedures when they perform, it's also the occupational workers who are also getting into it. And there, in that case, the radiation safety body's stipulation become more binding than, of course, other than the health ministry part of it, everything. So in all these cases, the kind of the thing can be right from infrastructure, quality management system, radiation protection program. These are all the facilities, what I will call as something like, your hardware type of thing which should be there in place, and then the software equivalent in the practices, operation and maintenance, standard operating procedures, education and training, what we call fit for the job being there to be ensured, And in order to do that, in addition to the periodic other reviews, like your own doing a self-evaluation, intercomparison exercises, participating for the dosimetry, QA type of things, like having and instituting and effectively functioning a local safety committee, and periodically having a peer review, your own friendly other medical institutions or from the professional bodies receiving people to have a review of your status of adherence, in addition to whatever will be done as a inspection by the AERB. But by the sheer number of the licensees, it's only a fraction of that can be covered in any kind of a year, and in whatever manner randomly we will do it also. So therefore that other part of that self thing becomes extremely important. The global support wise, when we say the IAEA, WHO, I told you the joint roles, because most of the countries health related thing, World Health Organization will be the one who would be looking at it and doing, and therefore that becomes important to get the stamp of approval of whatever recommendations come. So the IAEA, WHO working in close relation needed, and fortunately that exists, a variety of number of things are there, that helps. That does not mean there is no role. There is plenty of role for the professional bodies which are expertise based, and many of them are nationally also. Then many of the state national governments do derive all their strength from that in terms of adapting and fostering standards. Diagnostic reference level. This applies in the case of the imaging type of studies where there is a diagnostic reference level. That's why I put DR and nuclear medicine, it comes. And then sharing of good practices and so on and so forth. Valuable guidance. I just showed two of them, one from the ICRP and one from the IAEA thing but many of the national ones are also equally good. Many of them are derived, and many of these national experts have only contributed to those IAEA or ICRP type of documents which have come out also. Advocacy of the radiation safety culture. This is again a globally common initiative to make sure it comes, and it also came up in earlier one of the presentation by Koleji also, to encompass, the main thing will be just to encompass all the practices, facilities and the stakeholders. You can also go for the review or audit of your radiation medicine practices by expert bodies. IAEA has two schemes, one for the radiation oncology, Quattro, one for the QANM, or their equivalent can be created internally, nationally also, and then applied in a number of these places, So one of the major one, it has been contributed to our pride that by one of our own Indian medical physicists, Dr. Madan Rahani. He started this, what is called the RPOP, Radiation Protection of Patients, an IAEA web-based arrangement, which contains a world of information, encyclopedia like. And that's been one of the most sought after things by practically all the stakeholders, plenty of resources and information on that. Naturally, much of the emphasis there is the medical exposure to the patients, the means to minimize and avoiding unnecessary exposures. Like that comes under the medical exposure. So we have less from our AERB type of thing to do there, but that's something important. Together they have to be there. So that's already mentioned in this RPOP, the largest number of hits it gets. But more importantly, in 2012, there was a BARC call for action. There was an international conference, and in which the necessity to address issues in radiation protection in medicine was done. And then this was also followed up by a 5 years later conference in Vienna. 10 years down the line, now 27, I think there should be the next follow-up conference on that. One of the important points which came from there is a 10-point agenda, something like 10 commandments, out of which 3, 4 are again like what we have already mentioned about few things. Just to add to one more feather to Rehani's cap, they have another website in which once again plenty of very useful information is available. That's what is shown on the bottom most of that. Now the BARC call for action, 10 actions, some of them are whatever we call our regular telling motherhood saying enhance the implementation of the principle of justification, principle of optimization. But more important are there, strengthen the manufacturer's role, education and training of the health professionals, radiation safety culture, then implementation of safety requirements globally. I found out of the 10, these 4 and the underlined text part to be more relevant with reference to what we are covering today and talking here. So I just put that, but all the 10 and each one of them have many of the sub-action points also. The document is all freely downloadable, available. This is something where a very large number of nations were represented. They were party to it, so including our own Ministry of Health representatives there. So this provides a kind of a thing of what should be done with reference to the thing in order to improve the radiation protection safety in medicine. This includes everything, overall infrastructure. Even though in my title that infrastructure word was there, I think all of them collectively are important. So these 10 are those points. It includes research. There was some question in the morning by, I think, Bamraji only or somebody, I remember, with reference to the research associated who is doing or what it is. They have put a point there also. Shape and promote a strategic research agenda for radiation protection in medicine here. Now, the issues, challenges. Again, the man here becomes the very first one. The qualified staff, availability, their education, training, that's one common thing, not only in India, practically in many other places. The word RSO is very easily said, but an effectively functioning one to get in these kind of the medical facilities with a full management commitment, only it will be possible. Then in terms of the approval of the equipment system, we'll be dwelling on that in, I think in one more slide also, because there is a kind of equipment wanting to come. We do have a type approval from the radiation safety point of view. But in a medical, there is also that medical technology related piece of it, the imaging system itself or the treatment system, which needs to have a thing so that comes under that medical devices type. Now, finally, there had been a plan that with reference to that, there should be inclusion. Once again, AERB had been involved. I think Dr. Sonavane was there, a member in that. But draft of that new drugs, medical devices, cosmetics. I remember July 22, it was there, and there were comments to be submitted within 45 days, and I had coordinated with reference certain part of that area with DAE, and some response was submitted. But to my best of my knowledge, it's not yet there. So the medical devices are supposed to be getting covered there. So till then, again, this overlap, we can clear with reference to the safety point of view. But what about the medical technology itself, imaging or treatment per se, that comes. The human resources, like many of the places we face, first-tier cities, Bombay or Bangalore, people might be willing to stay, but come to another level city like Coimbatore, Mysore or places, people attrition rate will be there because they would like to move to the other places. This repeatedly creates a problem. Then career prospects related. Medical people are fine, but scientists, technologists have fairly very high degree of qualification. When they don't have too many things like this also becomes. I already mentioned about the location piece. And most important is the technology has been continuously, rapidly growing. growing. So to keep pace with the technology advances, that's been another challenge for the people, particularly the paramedical other group. Like we have a continuing medical education, and that's a must for most of the doctors to continue their registration. But what about the allied professionals? There also these technologies have changed and they do need it. Like there is nothing like keeping easily a CAP. And then the greener pasture attraction. Of course, that way we had also lost a lot of people from India to abroad, but then I always remember Dr. Chidambaram's quotation. It's never a brain drain, it's only a brain overflow. This is what he used to tell, because our total N is so large, even after many people go, it should not matter. Like, but this is a problem for many of the other countries, African countries and other places. Invariably, whatever their original colony, the French-speaking people means they end up in France, the English-speaking go to England or Australia, and all the trained people like get depleted from there. Then vendor-related. Getting the certified equipment system. A system may be good, but when they want to sell it in India, now the first question will be, okay, go to ARB. ARB can approve only with reference to radiation safety related. Any other applicable, all clearances you should obtain. We will put our disclaimer. But for fellow, they don't have another very authentic arrangement yet. But this would be needed because nowadays we know, one of our neighbors, they have also been dumping a lot of equipment into the thing like, and you do need to have that certified equipment system arrangement. Annual maintenance, periodic maintenance, spares, and technology changes, therefore obsolescence. And there is nowadays availability of remote tech support, but in some of the countries or some of the parts of the countries, the connectivity may not be there. And in addition, always companies, they do have their own commercial competition, mergers, takeovers, names change, etc. These are all practical part of it. Like, very briefly, to quickly tell the three medical applications, because we do come from that area. Like the very first point is, I mentioned about the volume for the cancer. Statement is 50 to 70% of all cancer patients require radiation treatment at one time or the other. This comes from the medical community, the text. Therefore, like the type of volume or its importance, like, and then the time-tested use of radiation. Not today, since ages, this has been very clearly there. We do have both the methods, what's called the teletherapy or the external beam radiotherapy and the brachytherapy methods, using both radioisotopic based sources, by and large cobalt for the external therapy and iridium for the brachytherapy, and machine generated. Electrons means from there the Bremsstrahlung X-rays which you get, that's what you use. Then you have protons, all are available today. But the LINAC based, that is the linear accelerator based X-ray delivery starting from electrons, or go into up to the latest one like hadrons. All of them, they have much distinctly superior features, so they are sort of really taking over. The radioactive isotope based, cobalt based have been declined and reducing further, except for brachytherapy where there is not yet any effective alternate technology available. This is the type of the total arrangement. Like, and in all the parts, the QA, the radiation safety wise, dosimetry management becomes the very crucial requisite. And as many of you will know, like cancer treatment does not take place just in one day. There will be 20 sittings, 10 sittings, 30 sittings, 40 sittings like of the patient. And the one key point which we have practically seen by taking our own family people when we have to go for the treatment is the radiotherapy technologist really becomes the central core, because that group of the people are who are the ones who are day in and day out operating. Medical physicists are there, they will do the treatment planning, calculation goes. So the extent of the skill and the safety and other knowledge of that person becomes the most crucial, even though all the other people, radiation oncologists, they all have their own role. Like, in India, what's the picture? Ghanshyam Sahani was nice enough to give me the data. 700 centers, and we need definitely RSO everywhere. Total number of RSOs available comes to almost making it around 1.5 per center. Like every year, 73 candidates could be getting qualified. And in the last year, 10 years, every year about 33 centers have actually been getting added on. Like we have a safety code with reference to that. I don't need to read the challenges, because whatever I mentioned in the global context is equally applicable in all our cases also. So all those bullet points on which more extended information is available from RASD, AERB is there for anybody interested. And this is actually our Indian scenario. Now we move to the nuclear medicine. where it's for both diagnostic and therapy. I told therapy has been originally to begin with small, now that is growing. Diagnostic is about 80 to 85% of the practices. The one important key point here is this is beyond cancer. This is not only for cancer, it's in the case of heart ailments, infection, neurology, and its versatility is such it has plenty. I wanted to specifically put that word there is also for certain pediatric patients, because we have been knowing about and communication, radiation safety, fear people we talked, and where there is a field in our thing, pediatric, some specific children require some diagnostic procedure, there is a well-established, very safe mechanism of running a nuclear medicine practice. The second thing is the open sources, the form of radiopharmaceuticals. That is extremely important. The radiotherapy or diagnostic radiology equipment is there, technologists, doctors, they operate. In this case, week after week, the particular isotope and that product has to go on. And in the case of imaging, again, there have been continual growth. The last 20-25 years, what has come striking is this PET-CT. 2001, it got introduced, the hybrid imaging. PET itself was a world-known positron emission tomography, possibilities, potentials, everything was known, but it has grown such a way. Within last 15-20 years, we take, I think now we have about 400 plus or almost touching 500 kind of centers having the PET-CT facility. And this is one thing which really has made a change in the medical management part, and therefore it has got much more easily accepted. While it took the conventional nuclear medicine much longer time to get established, PET-CT has been able to go. Linked with that has been the tumor therapy, that is the radiopharmaceutical systemic therapy. Instead of your external beam therapy or brachytherapy, you administer a radioactive material which targets the tumors and take care of the therapy. And that field originally, which was mainly known for thyroid cancers, gone for other particular cancers now. And that's a growing field, and it's very clearly established, envisaged that will become a plenty of an important one in the future. And correspondingly, the advances in the radiopharmaceuticals as well as in the instrumentation systems are there. Here again, the nuclear medicine technologist becomes the one who on day-to-day basis doing, and their skills, his or her skill and their abilities is overall determining what it is like. Again, the Indian scenario, 560 nuclear medicine centers, about 680 RSOs, that means around 1.2. Every year 72 are qualifying, and 35 new nuclear medicine centers over the last 10 years have come. In this case also, practically all the other type of thing what we said will be there. In addition, there would be two more things, because they are all open sources. You do have a radiopharmaceutical type of operation involved in hospital end, preparing, formulating the project, as well as radioactive waste generated. Fortunately, most of them are shorter half-life, but iodine 8 days, iodine 131 8 days half-life, lutetium 177 6.7 days half-life. They are the only one relatively of longer half-life isotopes involved. There are enough procedures, again we have a code for that, and this is the current situation. Because I did ask for and collected this information from RSD, I want to show why we say like the DR is far too huge. It's to be sort of, I'm omitting it from my talk for convenience, because the so-called special facilities of computer tomography interventional itself are coming to over 11,000 institutes. And there are about 25,000 radiation professionals. If you leave that select group and take it as the entire diagnostic, it's absolutely, probably a two orders of magnitude higher numbers. That really makes it. So therefore, the sheer huge volumes pose challenges, self-control, self-regulation, self-discipline, except that it's going to be extremely, difficult that they are going to maintain any kind of a safety like. There is, just before concluding, one most important aspect with reference to when we talk about radiation protection and safety in radiation medicine is the diverse health status of the patients. We are talking here about patients to be the end beneficiaries. We are not having kind of a regular operating plant and all healthy personnel, healthy equipment type. Here they are actually having their own. And in our Indian type of context, the literacy level also matters. So this will have, because some minimal physical abilities of the patient is needed in order to receive the diagnostic or the therapeutic procedure. And that would be compromised because of their own health status and literacy. This can have an impact on the image quality. The treatment plan could go topsy-turvy. The therapy efficacy may not be there. The radioactive waste, particularly in the case of the nuclear medicine, will be there. And what will be reported back as to the physician because of the patient health. So any regulatory stipulatory requirements will have to reckon with that, which indirectly means repetition of procedure additional exposure, be it to the patient or because of that to the occupational worker, is inescapable. It's an intrinsic part, it exists, and that is what all the radiation workers, radiation professionals are going through. Of course, fostering the use of guidance, good practices, lessons, etc. would be helpful, the role of the professional global bodies, but this is something extremely unique with reference to the radiation medicine. There, when we are talking about protection and safety, you can't put a baseline, say this is the level of health everybody's has been assumed like, and that will not be able to work. So a 5-point advocacy, what could be there is holistic approach to the safety. Now I am picking on Frederick Law also the word, because there are some security related source issues. We did not touch it at all, but when we say the holistic approach of safety, that would include that also. Then leveraging international advisory guidance, good practices which are available, the culture, safety culture, protection culture, which we said, and also link the synergies of the safety and quality management in the entire procedures. Management commitment, this according to me is absolutely uncompromisable. That's what we need to ensure and get. Then everything can be manageable, workable well. Of course, responsible conduct. It's not only the management. Every one of the team member is responsible. Responsible conduct by every member in the team. Man behind, man or woman behind at the entire thing. Their competency, availability, consistent with the technical advances taking place. With all that, you cannot put it on them only. There has to be the national governmental responsibility in terms of setting up of the laws, and that's where I said draft of the new drugs, medical devices, cosmetics bill. Because when we talk about this, that kind of a governmental thing is also an absolute must So what's the bottom line? Radiation applications in healthcare are far too important to be left to the impact of any vulnerability, vagary, gap in safety compliance. This is the real fundamental point, because there could be many things, but the total application and the end use and what needs to be done is far too high to be left to any kind of this type of impact. So there will have to be an overarching duty, overarching commitment for the entire global national radiation medicine community to sustainably ensure safety of the facilities and practices, and that in turn of the patients, occupational workers, and the associated persons like. There is a famous good old saying which we keep on always telling the people: discretion is the better part of valor. It comes supposed to come from William Shakespeare. The idea is that, don't just be overconfident, everything will be manageable. Discretion is better, that's what applies in the safety security, particularly for the medical dealing with patients. My own addition is that what's famous thing is prevention is better than cure, what is said in medicine. I cut the word cure, I say prevention is better than mitigation, and that's the importance of our entire work. So I thank you all for this opportunity and for the patient listening. I hope I am just within my time limit. I am happy to take, and my email ID is given. Any comments, criticisms, any other queries, please do feel free. Thank you all. Thank you.